She's sometimes sad, she's sometimes happy. She's doing things to make her life less crappy. Trying a treatment that's new on the scene. Let's sit back and talk about ketamine.
Hey, welcome to episode 3 of Ketamineinsights. We're going to compare ketamine to other options when it comes to treating depression in this episode. Early in the episode, we talk about different reasons a given person's depression might be what's called treatment resistant. That means it might not respond to standard treatments like SSRI medications, for example. To zoom out real quick, our understanding of illnesses changes over time, changes over cultures. It just changes as we learn more and as our perspective changes. What I think about depression is that we'll one day come to understand that what we now call depression is better described as several different illnesses with different causes, and they each will need different kinds of interventions. Even now, a lot of doctors see depression more as a syndrome, which is to say that it's actually a collection of pretty diverse symptoms. And those symptoms include low mood, but they also include things like changes in appetite, slower movement, slower speech, and cognitive issues. So right now, the way the diagnostic criteria is set up in the US, it's possible for two people with completely different collections of symptoms to both qualify as depressed. So what I'm trying to say in this episode is that if you have what's called treatment-resistant depression, and the underlying reason for that collection of symptoms is actually a hormonal issue, for example, or sleep issues, or unresolved trauma, then the standard depression treatments often will not work. So if you're experiencing several medications not working, it may be worth looking into those other causes. You'll also hear in this episode me displaying some very bad math while Lynn and I are talking about something called ECT, which is electroconvulsive therapy. The truth is that I have pretty serious ongoing cognitive effects from going through ECT several years ago. My concentration is worse. I still have pretty bad memory. And apparently sometimes I can't do simple math. We don't employ fact checkers here. I just want to mention real quick. So we don't employ anyone. So please understand that all of the content in this episode is really just a list of things for you to research yourself. Google around, be empowered, and research. And finally, this time around, I just have one request, which is share this episode. Share this podcast. Please share it on social media. Text a friend. Word of mouth is really important for new podcasts. After just 2 episodes, this tiny little podcast with literally no budget has been downloaded already in 78 cities on 6 different continents. So spread the word. We're getting out there. I really appreciate it. Welcome to episode 3. We are recording. Hey, everybody. This is episode 3 of Ketamineinsights. I'm your one host, Molly, and this is
Lynn.
Okay, so today we are going to talk about how ketamine compares to other treatments for treatment-resistant depression. We're concentrating on treatment-resistant depression because right now in America, right now you're really only supposed to do ketamine infusions for treatment-resistant depression, not regular depression, I guess. I don't know. The only thing that makes depression treatment-resistant is you have to have tried 2 pharmaceutical antidepressants. And I hate this term, but they say you have to have failed 2 antidepressants as if you're the one that's failing as opposed to the medicine. Today we're just going to do a list of other options that you should know about if you're considering ketamine, the other things that are available to you before.
And just to clarify, Molly, as someone who's not a patient, failed means that they just didn't work for you. They just didn't make you feel better.
Exactly.
The antidepressants. Yeah. Okay.
Yeah. Or maybe they worked for a little bit and then stopped working.
Okay.
Yeah. I'm not sure about if you didn't tolerate them well, if that counts as failing, that's a good question. Like if you couldn't, if there were side effects and you stopped taking the medication, if that counts. I don't know. I'll have to look that up.
Because that seems like maybe that doesn't count as treatment. I don't know. I shouldn't talk. Treatment resistant. If like it made you feel better, but you had side effects, so then you had to try something else. Maybe, I don't know.
I mean, sometimes the side effects, like, if it's like, impotence and enormous weight gain and night sweats, like they can be pretty bad.
Yeah.
But a lot of the time they're not as bad as the depression. So
of course,
kind of up to every individual.
Yeah. You have to decide for
and
yourself.
I think we're a lot less like tolerant of side effects the first medication we take. The second medication we take. Once you're on medication number like 7, you're like, I don't care. I'll do anything to
accept it.
Get rid of this depression. Yeah.
Yeah.
So, and most people like have, a depressive episode at one point in their lives and either get help or don't, and they recover fully and they don't ever qualify as treatment resistant, thankfully.
Yeah.
So anyway, this is like a really incomplete list of treatments for depression. It doesn't include, like, I left out all the holistic stuff like mindfulness based stress reduction and light therapy and acupuncture and all that stuff, which can be really helpful. But this is more like the pharmaceutical stuff or the more medical stuff that people turn to once it's pretty bad.
Okay.
So just real quick, I wanted to but talk about some reasons for treatment resistance that people don't often realize. And these are actually taken directly from a different podcast called Back from the Abyss. And there's an episode that's called When Meds Don't Work, and I really recommend it. I have mixed feelings about Back from the Abyss, but some of their episodes are really great. So just real quick, like there's 5, he names 5 reasons for treatment resistance. And the first one is mistaken expectations, which I think kind of maybe doesn't even belong on the list. The idea is that you expect it to work more than it does or faster than it does, and that's just unrealistic. The second one is sleep issues. So if you have really bad insomnia or some really bad like sleep condition that makes you sleepy all the time, it can lead to depressive symptoms that aren't really depression. The same is true of trauma. So like if you have PTSD, it could lead to depression, or if you are ongoing trauma. I think that's something like we don't think about as like, we think about like big past trauma as like an event, but there's also just like ongoing trauma, of course, that happens to a lot of people, and it can make you look depressed when you don't actually have like clinical depression. Sometimes there's just a misdiagnosis, like you actually are bipolar. And I was, for a little while, they thought I might have something called, I forget what it's called. It's like bipolar without the manic part. And I'm like, isn't that just depression?
Yeah, I was going to say, where's the bi?
Exactly. That just sounds like what I have, which is being really sad all the time.
Yeah, I don't understand. Where's the other half of that?
Yeah, I think the reason they differentiate is just that, like, for those patients, mood stabilizers work and antidepressants don't.
Okay.
It's like kind of a backwards way of diagnosing something, it seems like.
Oh, I'm not sure I understand the difference between a mood stabilizer and an antidepressant.
The only difference is that a mood stabilizer is meant for people with bipolar.
Okay.
So they're basically saying, like, if the treatment is what commonly works for people with bipolar, even though you only feel depressed, you really have bipolar because the medications for bipolar are what works for you.
Yeah.
It's a
and
weird...
you're probably thinking, I wish I had that mania. Could use that up every now and then.
Oh my God. Completely.
Yeah.
I'm like that. I mean, I know it's no joke, and like people, do bad things when they have it, like it's rough, but like, there is definitely a little inclination that's like, man, I'd love to feel really energetic and excited for even a couple days at a time.
Yeah.
Yeah. That felt like a real, I was like, come on, you guys, like unipolar, bipolar, like don't give me that. I don't know. So anyway, but it does happen often that there's just a misdiagnosis, whether it's bipolar or something else. And the final one is just hormone imbalances, which can happen a lot, especially like after a pregnancy, things like that. And we don't realize like our hormones change throughout our entire lives, not just like during puberty. And so anyway, those are some quick reasons for treatment resistance that need to be looked into or should be looked into. And a lot of doctors won't, a lot of psychiatrists won't get you tested for hormone imbalances, for example. So on to the treatments for for treatment resistant depression. The first simple one is talk therapy. The only thing I really want to say here is that I think one common misconception is that like the type of therapy, people overestimate the importance of the type of therapy. So there's like just dozens of different approaches that different therapists take. And the studies show that it doesn't really matter which approach a given patient gets. What matters more is like kind of the vibe between the patient and the therapist. So I would say like, I would always recommend interview the therapist before you start the therapeutic relationship, and don't ask them, questions about like their credentials and what approaches they use, but like, I don't know, ask them random shit that makes you decide whether or not you like them as a person. I think that's more helpful. Like, an interview question I heard recently was like, what tabs do you have open on your computer right now? It just like tells you, they can leave a couple out if they want to, but like it tells you kind of what they're into, that kind of thing. Well,
that's great advice. Yeah, the vibe. I like that. That's so interesting because I feel like, my inclination would be like, what is your approach? What's your training in?
Right.
But
and the truth of the matter is most patients or clients, as therapists call us, like wouldn't know enough about the approach to know what's best for them. What's the difference between cognitive behavioral therapy and dialectic behavioral therapy? Like most people don't know. And why would they?
No, it's so true. It's so true. I have a bunch of therapists in my family, my in-laws. I'm married into a bunch. And so I feel like I'm always hearing about all these different approaches. So I feel like, my therapist search would always be like, okay, well, tell me, do you, which of these 5 approaches do you use? But the vibe approach, looking for the vibe seems like it makes a lot more sense because that's what really matters.
It's funny because like even therapists will say like they're aware of those studies, and when you go on to like the website Psychology Today and search for therapists in your city, they don't talk about themselves really. They more talk about which approaches they use, and and you can't really tell a vibe from a blurb anyway. You kind of have to do the interview and give them a call. And most therapists, if they're good, will do like a free 20-minute call before you start. So there's also a bunch of like misconceptions about pharmaceuticals that I just want to review talk about real quick. There is another really helpful, again, like a Back from the Abyss podcast episode called, it's only 16 minutes long, this episode, and it's called Almost Everything About Psych Meds. And I found it really, really helpful. What people don't realize is that there's a bunch of different types, like there's a bunch of different categories of antidepressants. And it's not really helpful to try several of the same type in a row. So a lot of psychiatrists will prescribe you an SSRI. And then if that doesn't work for you, they'll prescribe you a second SSRI. And that's just not, like, my understanding is that's not a great idea. And a lot of psychiatrists actually say SSRIs are much more effective for anxiety than they are for depression. And they shouldn't be the first round of antidepressants that we use. But that's like, I guess, an ongoing debate. So anyway, that's the first type of antidepressant is SSRIs. There's another category called SSNI. And then there's a category called atypical antidepressants. These are just like things that are worth Googling if you're being prescribed antidepressants and try to understand the differences between them. Some of them have like different categories of side effects, for example. If you don't mind, gaining weight, but you don't want to deal with sexual side effects, then you might want an atypical antidepressant as opposed to an SSRI, for example. And then the final one, or one that I think is really important to talk about, is the fourth one here is MAOIs. They're not prescribed often anymore at all, but they're actually really effective. They were the first type of antidepressant that was discovered, and they're not used because they come with a lot of dietary restrictions that are actually like absurd and they are actually difficult to follow, because it's like hard to even remember what counts. So like what the thing you're avoiding, tyramine, is like this chemical that you're trying to avoid, but tyramine, like the amount of tyramine in a given food will change over time. So you can eat a banana, but you can't eat an overripe banana. That's
so frustrating. That's something they say to avoid for migraine too. But I've also never really tried to avoid it because it seems really annoying. And you're supposed to, it's like an avocado maybe too.
Yep. You can't have avocados. You can't have cured meats like bacon.
Yeah. I can't handle it. Yeah.
You can't have like any cheese besides like American cheese, which is American cheese even a cheese?
It's not cheese. It's like processed cheese food. Yeah.
Yeah. You can't have tofu. I'm like, as a vegetarian, if I can't have yogurt, I can't have tofu. No soy sauce, no cheese.
It's not going to work.
Yeah, it's really hard. And the thing is, like, if you do eat too many of those foods, if you have like too much beer, it's not that the medication won't work. It's that you're at risk for a stroke.
What?
It's very
scary.
Serious. Yeah.
That's super scary.
A lot of psychiatrists, even though these are effective medications, don't want to prescribe them because they don't want to be responsible for you following the dietary restrictions. And like, I don't know, it depends on how bad your depression is. You know what I mean? If it's really bad, you might be very grateful to skip cheese, and maybe you don't drink anyway because drinking is a depressant, and there's one important exception to this. They found a different way to give antidepressant, like to give MAOIs into your body. So there's something called a transdermal patch, and that is just a little sticker that you put on your skin every day, and it is a way to get an MAOI that they're pretty sure avoids all the dietary restrictions altogether.
Wow.
Because the MAOI medication itself isn't going through your stomach.
Interesting.
And there's different doses. So this particular patch is called MSAM, and it's worth looking into if you've tried a couple of antidepressants that didn't work.
Have you tried that?
Yeah, actually, yeah. And I found it really helpful. I have one on which arm? It's on this arm right now.
Oh, nice.
You can see it's just like a clear little patch. I think there's like a similar one for like, it's like, looks like a nicotine patch.
Yeah.
And if you're on the lowest dose of it, then you can eat whatever you want.
Cool.
Yeah, and there's chances are if you're on a higher dose, you can also eat whatever you want. They just haven't officially studied it. But like anecdotally, from my understanding, there's no record of stroke. It's like,
better safe than sorry.
Yeah, right. They say like introduce tofu slowly and see if you freak out. And if you don't, you're probably fine. It's like,
it's kind of scary.
Yeah, it is. Like,
especially as a vegetarian.
Right. Yeah. And some people are just like, I might be depressed, but if I can't have bacon, I'm just going to be more depressed.
Yeah. Need that bacon.
So it's just kind of like a matter of being aware of what your options are. You know what I mean? And like knowing what to Google. Because a lot of psychiatrists won't lay out the different options. They'll just be like, okay, well, Butrin is next for you. And you're like, what's Butrin?
Yeah. And it might be just the next SSRI after SSRI. And
That's messed up how many people.
It is good to know about all of those things. That's super helpful.
Yeah, you don't find these like lists anywhere.
No.
Unless you know to look for them. Yeah. So anyway, just real quick, the last two, there are antipsychotics, like technically drugs that are classified as antipsychotics or as mood stabilizers that sometimes just work for depression. Like we were saying earlier about like Abilify is one that is technically a mood stabilizer, but it is also known as like a helper drug. So you can take an SSRI, and then if you add Abilify, sometimes that makes the SSRI work better, is the idea.
Okay.
And finally, there are some medications that could be helpful for easing like the compounding problems around depression. So those are like sleep medications, anxiety medications that, often sleep problems and anxiety coexist. So those can be helpful, like helping you. If you're not sleeping well, you're not getting better in a lot of cases,
That's right.
Okay, so that's it for the pharmaceuticals. I feel like that's that's like the thing that most people know about when it comes to treating depression. But there are two other ones we're going to talk about today that are really only used when you've tried a bunch of medications, they haven't worked, or a handful. The first one is transcranial magnetic stimulation. It's TMS is what it's known as, because that's a lot of syllables, transcranial magnetic stimulation.
Interesting.
And it's a commitment. It's 6 to 9 weeks. And the first 6 weeks, you're going every day for an hour.
Wow.
And you sit in this big chair. And the idea is like, so we know that like your heart has an electrical, like there's chemical stuff going on, but there's also like an electrical, right? Like when you put a pacemaker in your heart, it's like sending electrical signals to make your heart beat. So your brain is similar. It has like there's like an electrical, I don't know what you'd call it, like aspect to your brain as well.
Yeah. Like it's got its own little current going on.
Sorry, Lynn, what'd you say?
It's got its own little current, like a little electrical current. I never thought about any of this before. I never really, okay. I have a little picture in my mind of the chair you're talking about, like a little.
It's so strange. It's like.
You've done this?
Yeah. You go like, you sit in this big chair. They put like it looks like something from a cartoon of like, you're talking to aliens.
Like a little cap. Like a little cap goes over you.
Yeah, that's exactly what happens. You got it. So it like comes out over your head, like almost like you're getting your hair blow dried or something. Yeah. And
wow.
What they do is like they put magnets on your brain for like 10 or I can't remember if it's like 10 or 15 seconds every minute for like 45 minutes.
Interesting.
And when the magnet is on, it feels like a woodpecker hitting your head.
Ah.
So it's properly painful.
Yeah.
The good thing is
wow.
like it doesn't like as soon as the magnet is no longer hitting, like feels like it's hitting you, you don't feel like you just got hit.
Okay.
So you don't have that like ongoing,
It completely stops.
Yeah,
completely,
you don't have that like
stops. Okay,
exactly. You don't have that like ongoing ache as if someone just like poked you in the head. Yeah. So it goes poke, 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 poke.
It feels in the head, not in your brain. You feel the magnets. It's like in your head. It's like on your okay, because it's like the magnets are hitting your skull. It's not like it. You don't feel it inside. Okay.
Yeah. You don't feel like your brain is spasming so much as like something's just like hitting your head. Yeah.
Okay.
And there's like different, they do different like parts of the brain or whatever, depending on your symptoms.
Is it super loud too, the machine?
Yep.
Like an MRI. Have you had an MRI before? Imagine it
it's
sounds
not quite
like that.
loud.
Like, okay.
But it is loud. It's like, pop, 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 pop.
Okay.
Yeah, for 10 or 15 seconds. And then it's over. And at first you're like, what the hell is happening? Like, where is my life? Like why, how did this become my life? But after a while, you're kind of like, I ended up with a really cool technician. His name was Conrad. He was great, who like runs the machine. And he was going through graduate school for something mental health related. And we just like shot the shit. So you'd shoot the shit for a minute. Then there'd be 15 seconds of really loud tapping. Then you shoot the shit. You continue your conversation. It's like Wayne's World, like game on.
Interesting. That's wild. Every day for 6 to 9 weeks.
Day. Yeah.
That's so intense.
Every weekday. Yeah.
Every weekday. Okay.
For like an hour. And I've read articles that are like, a lot of people can't take off work that long. It's like, it's so annoying. Do your fact checking. That's not true. You don't have to take off work at all. You're completely fine, sober, normal once it's over. You can drive home. You can go to work. You don't need to like go to therapy after. It's not like ketamine in that way. They just tap your head and then you go about your business.
Yeah. It's just an hour.
It's an hour out of every day.
Okay. And do you feel some relief immediately afterward, or does it take time, like multiple sessions, to start feeling it?
Yeah, I think some people, I can't remember what the numbers are with respect to like how long it takes for most people, but it is a really high proportion. It does have a very good success rate. A lot of people find relief. And you have to think too about like with ketamine, TMS, and the next one we're going to talk about, ECT, electroconvulsive therapy. The people who are doing these are harder to treat people, you know? So a 50% success rate with a initial SSRI is different than a 50% success rate when it comes to TMS, because like these are patients who have already quote unquote failed a bunch of medications and probably talk therapy.
Yep.
So, but yeah, a lot of people feel better. I think it's like 3 or 4 weeks in and they continue to feel better throughout.
Okay.
But it's like, it's like, so I remember I would walk sometimes, it was miles to TMS, and I would walk because I was kind of so depressed. I wasn't working very much at all.
Yeah.
And I would pick up pennies on the way and be like, this penny will be my lucky penny and TMS will work for me.
Oh.
Yeah.
Wow.
And it didn't. And so, yeah, it's like, you know, as week 4 goes on and week 5 goes on, you're like, it's not working yet. Is it working yet? Do I feel better? Don't I feel better? But I think like TMS is actually, I don't know. It's fine. Like it's not, there aren't any other side effects besides like headache. You don't, you know, there's no sexual side effects. There's no like other side effects that a lot of these interventions have. So
yeah.
Insurance
you don't have
covers
to stay
it,
away
you know,
from
like,
certain foods.
Exactly. Yeah. There's definitely, and
That's
you don't have
nice.
to do it for the rest of your life. You just do it the once.
Yeah.
And maybe 5 years later, you have to go back for more or something. So, and the final one we'll talk about is a very big deal. Electroconvulsive therapy is like, a lot of people say like, oh, should I do ketamine or ECT? And honestly, my like hands down, do ketamine before you do ECT. ECT is very, very difficult to go through. Formerly called electroshock therapy. No longer called that. They're very sensitive about that. Which is, what is that movie? Is it like One Flew Over the Cuckoo's Nest or something, where the poor guy, they like strap him in, and I never saw the movie.
I mean, I know One Flew Over the Cuckoo's Nest. I don't know if they do electroshock therapy in that.
I know there's some
now
movie
known as
where,
ECT.
yeah, where they were trying to like introduce ECT as an option for me, and they were like, it's not like that movie. And I was like, I've never seen that movie, whatever it is. Like, so
There's also an episode of Homeland with Claire Danes where they do some kind of
really?
maybe it's ECT.
I used to love
She's
that
supposed
show.
to be bipolar in it, which, you know, maybe they don't do. I don't know if they do ECT for bipolar. I don't know how accurate that show is. I don't know if you've ever seen it, but I think like the final episode of season 1, she's doing something where they like put a mouth guard in her and they like strap her down and they're shocking her.
Yeah,
as some
that's
sort
what
of a
it's
treatment.
like. What they do is they put, so you actually go they what's the word? They sedate you completely, so you're out.
Okay.
And they you know, attach a bunch of electrodes to your head. They induce a seizure while you're anesthetized, and it requires months off of work. It works, I think, about 50% of the time. There's usually 12 sessions. 6 to 12 sessions, I think, is normal. And they do them like 3 times weekly. And you have to go into the hospital, obviously, and it's done in like a surgery room. And in my experience, so I did ECT, and what they kind of like line up the patients in a cot, like in their cots, like in a huge kind of surgery theater. And they go down the line. They do the first one, second one, third one. Luckily, well, the thing about ECT is it has very, very serious cognitive consequences. So it's 12 sessions, 3 times a week. So what is that? 4 months? Is that right? And
Yeah.
I did 16 treatments, I think. And you don't, I don't remember almost anything from those 4 months, 5 months during the time I was going through ECT. You also you actually lose memory. You lose the memory of your own history, your own biography temporarily. So for a while,
during that time, you don't remember who you are,
and up to about 6 months after even.
What?
Yeah. So
that's super scary.
You don't remember I knew who I was, I knew who my mom was, stuff like that, but I would forget friends. I would forget pretty profound things. I remember thinking, my mom was saying, well, you remember this and you remember that. And I was like, Mom, I don't know if you hit us when we were growing up.
Yeah.
Knowing you now, my guess is you didn't, but I don't remember.
Yeah.
So it really is destabilizing in that way.
That's really scary. Yeah.
And it's a last resort. It works. It works a lot of the time. I have family members for whom it's worked, and it's life-saving. For those people, because they're really, it's only used for people who are really severely depressed. And people say oh yeah, but you lose 6 months of your life. Well, with very serious treatment-resistant depression, you can lose decades,
Yeah.
So,
or you can lose your life.
Yeah, exactly. You can lose your entire life. So 6 months is a very big sacrifice, and it's also completely worth it if it works. The thing is, you do have the cognitive impairment and the memory loss, whether it works or not. So that was very truly, that was a very difficult thing to go through, because you never know what you forgot. For example, you can't tell, you run across things for the rest of your life that you don't know if you can't remember because that's normal, or if you can't remember because of ECT. There are things where I had one distant cousin who I had a really bad feeling about, and I couldn't remember why. I was like, I don't like her. I was like, why? I don't know why. I just had this gut, not that one.
Oh, weird.
And then I did remember years after ECT, and I was like, oh yeah. So it messes with you. And I think it's not really reasonable to compare it to ketamine. They're so different. I mean, they're
totally
used
different.
at similar points often in the depressives treatment journey, but they're really, really different. And there is one thing that I would recommend, if you're going to do ECT, or if you're thinking about it, request, go ahead and ask the surgeon, ask the anesthetist to use ketamine as the anesthesia, because that's what ketamine is originally. It's a tranquilizer. And a proper anesthesia. So for the last few treatments of ECT that I went through, ketamine was the drug that they used to anesthetize me. And there's one or two very small studies showing that ECT with ketamine as the anesthesia works better. And it's yeah, well, maybe that just might be the ketamine doing its thing. So that's it. I think the important thing is just to, we were saying earlier, just know what is possible, know the options that are available.
Absolutely.
I didn't know about ketamine
so
when
helpful.
I did ECT,
Oh, you didn't even know that you had this amazing option.
And
wow.
At the time, it wasn't really, I did it in 2018. Ketamine it was really rare there weren't ketamine clinics in most major cities in America like there are now. So,
so now people can skip ECT. They could skip even the TMS potentially and go straight to ketamine.
Yeah.
Which is gentler, it seems than probably both of those things.
I think so.
Even though it sounds like TMS isn't so rough.
Yeah. It's interesting because both TMS and ECT are really similar to pharmaceuticals. They're very medical interventions. They're not psychological, So in a lot of cases, I was pretty devastated when my psychiatrist said, it'll take up to 6 months for your memory to come back. And I said to him, well, will it take up to 6 months for me to feel better from the ECT? Yeah. And this was right after I had finished my 16th treatment. And he was like, oh, no, if it didn't work, it didn't work.
Oh,
and he said, sometimes with ECT, it can't work because you have such negative underlying beliefs that it saps your mood away. Like, you can artificially elevate the mood, but if you have psychological negative beliefs about yourself or the world or other people, those kind of chemical or technical, kind of physical interventions will only work for so long. And I was like, this sounds like a really good conversation to have had before I tried ECT.
Yeah.
Yeah.
Because those things are there. So
right.
ECT couldn't change that.
Yeah.
Whereas through ketamine, you do the psychological healing, right? And you gain insights that actually help you to shift those thoughts, those underlying beliefs.
Yeah.
Right?
Right. And that's, to me, the big
it's totally
difference.
different.
It's unique in that way. I don't know of other drugs where it helps both sides. It helps physically lift the mood, and it also helps with the psychological healing process and the growth that it takes to really build different psychological habits that keep you happier throughout the rest of your life. Ideally. Yeah.
Yeah.
So
interesting. Wow. I'm so glad you found ketamine. It's
Thank
a shame
you.
you didn't find it earlier.
I know, right? The all of these interventions sound, most of them, the ones we kind of got to later in the conversation, they can sound so drastic. But yeah, when you put up ketamine next to ECT, all of a sudden ketamine doesn't sound so drastic.
No, it does not.
Yeah.
Yeah.
And it might
but
be.
I'm sure, I was just going to say, for some people, though, it's it may sound quote unquote drastic, in a sort of in a way that because people think of it as a drug, because of the connotation it has, in our culture as, this as a psychedelic, because either it's used in a very medical way for anesthesia, or it's a street drug,
right, a
people
party
think
drug.
of it as in those ways. Yeah. Party drug. Exactly. And so it sounds drastic in that way, like using it in this way. Sounds like, oh my gosh, what are you doing? But really, it's much more gentle. You're not losing your memory for 6 months. Oh my gosh. And you don't have to be put into a seizure, have a seizure induced. I mean, that's crazy. It's so much easier on your body and mind, it sounds like, and it's so much more helpful for you. I understand. I mean, ECT could be something that is helpful for others, but it just seems so much more gentle.
And there's
so much more healthy.
There's a movement within the mental health world right now too, to say so if ketamine works maybe 70% of the time for people with depression, why are we using drugs that work 30% of the time first and making people go through, 6 to 12 weeks with one drug and then 6 to 12 weeks with the next drug because it takes that long for them to work at all, to tell if they're working. And then you have to often try different doses of that SSRI and then of that SNRI, or, so why are we doing those interventions first? Why don't we just treat people with ketamine? And
I didn't realize ketamine worked 70% of the time.
It's a very high percentage. Yeah. It's a very
that's
high
wild.
Success rate. And the thing is there's also, sometimes you do have to, people who do find ketamine very helpful, like me, have to continue to use ketamine for years. And so some people consider that a real detractor. Also, you have to take a pharmaceutical every day. It might not take quite as much time as ketamine, and it's covered by insurance, but those are, especially the insurance thing. It's well, that's just a technicality. I mean, obviously it's a huge deal. It's a big impact on my finances personally, but that's artificial. It doesn't have to be that way. And the argument to the pharmaceutical company, or to the insurance companies rather, is why are we covering less effective interventions and not covering the more effective one.
Yeah, absolutely.
So,
but because it's this psychedelic, that has a certain connotation, it's just going to take a while. It's this cultural shift that's happening, right? I imagine that that's a big part of why
it's a real weird situation. Like the drug itself is generic and very cheap.
Okay.
Ketamine is very cheap to make. When I go in for like a $400 infusion, the drug costs about $1.50.
What?
Yeah.
Wow.
And the thing that you're paying for is the clinic, the nurse, the physician who, all of the professional services around it. And those $400 don't include my therapist who sits there. So if you have to do that every month, every 6 weeks, like that's rent for a lot of people,
Yeah, absolutely. So interesting. So there's like nothing, big pharma isn't earning anything off of it. Although, maybe they could somehow find a way to.
And that's
eventually.
What the nasal spray is. The only way they could patent it was to give it a different method.
Yeah, put it in some form.
Yeah.
Yeah. And they'll probably find other ways to, What do they call it again? The nasal spray?
Spravato.
Spravato. That's right. I knew it was like something that makes you into a superhero.
Yeah.
I'm sure they'll find different ones too.
Yeah, the patch.
Different ways.
Yep.
Yeah.
Same kind of thing.
Yeah. They'll continue to do that.
And
I'm
it's
sure
so funny
do that
to
with
me,
other
right?
psychedelics.
It's the nasal spray. It's the least effective way to take it, but it's the only thing that could be patented. So it's the only thing that's covered by insurance.
Yeah.
Because the pharmaceutical companies paid to get it approved by the FDA. But it's like such a backward system where it's like the drug itself is cheap. So, but it's not approved yet for depression. It's an off-label use unless they're doing the nasal spray. So it's just a really silly situation. I know like in England and Ireland, it's getting approved directly. I think it's going through that process right now. So,
I bet we'll get there.
Yeah, eventually.
Situation's evolving.
Yes, exactly.
Yeah.
Yeah. Well, anyway, we should probably call it a day for this episode.
Yeah.
All right. Thanks so much, Lynn. Talk to you soon.
All right. Thanks, Molly.
Bye. How do I stop? Here we go. And that was episode 3. Thanks so much for joining us. Your co-hosts, Lynn Schneider and me, Molly Dunn. I do the other stuff except for the theme song, which was done by Solid State Symphony. This time around, I just have one request, which is please share this podcast with your mom, with your therapist, with your ketamine provider, with anybody who you think might benefit. We're really excited to reach 100 cities. And we're also excited to see you next week when we'll talk about something else real cool. Bye.